So first I'm going to talk about why MRI for the female pelvis when ultrasound continues to improve daily. What role do we have for MR? What our protocol is, some technique advice, as well as to go through certain cases where MR was useful to us, certain clinical cases, and to present some applications of evaluation of the female pelvis with MR. We're going to really focus more on benign disease. I'm going to sort of touch on malignant disease, but I think the focus is really going to be on benign disease. So why MR for the female pelvis? Well, some of the advantages include the lack of ionizing radiation when compared to CT. We use safer contrast agent, and we can really see over a larger field of view when compared to ultrasound. It's also less operator dependent than ultrasound, for example. It offers superior contrast resolution, inherent multiplanar capability, and enables you to characterize tissue, get real information regarding tissue details about hemorrhage, blood, fat, as well as other entities. And you're also able to do dynamic interactive imaging as well. So the planes that we try to achieve, and we really cater each exam to the patient, whether it's a pregnant patient or a non-pregnant patient, depending whether the exam is of the uterus or of the cervix, we will cater our planes to that patient and that patient's particular anatomy. And that's one of the useful things about MR, being able to adjust your examination depending on the patient's needs. So here's an example of a patient where, in this particular exam, we may be looking at the urethra. So we get an axial view through the urethra, try to cut our plane perpendicular to the urethra to get good axial views to see the normal bullseye appearance of the urethra, the normal W or H shape of the vagina and rectum, as well as to look at the levator musculature, which will play a role in dynamic pelvic imaging. If, for example, in this case, we're trying to look at the uterus itself, we cater our exam to this particular uterus, which is anteverted. We take a coronal slice of the uterus, a very important view to obtain, particularly when looking at uterine anomalies, when you really want to see that fundal contour. And one of the other things that I just want to point out is the detail of zonal anatomy that we see here, the normal high signal of the endometrial cavity, the low signal in the junctional zone, and the intermediate signal intensity of the myometrium, which also plays a significant role in your evaluation of the female pelvis. As I mentioned, MR is particularly useful for characterizing certain masses and certain tissues, as in this case where we have bilateral adnexal masses here and here. We have a large fibroid within the uterus here, as well as a low signal focus in this right adnexal mass. You can see the normal ovarian tissue sort of circumferentially surrounding this mass. We begin with doing T2 multiplanar images and proceed to do T1 images with and without fat suppression. And we use frequency selected fat suppression to see, as in this case, we have T1 hyperintense signal in both these masses. This could be blood, this could be mucin, this could be fat. With the frequency selected fat suppression, we can easily distinguish that this represents macroscopic fat, and these are bilateral dermoid tumors. A very easy diagnosis to make with MR. In addition, it's particularly helpful in patients with endometriosis or patients with hemorrhagic adnexal masses. Here we have axial T2 weighted images. We see some fluid in the pelvis and the cul-de-sac, as well as bilateral cystic masses in both adnexa. On the T1 weighted images, we see that there are high signal foci in the right adnexa, as well as tracking along the sacrouterine ligaments, and the fluid that we saw on the T2 actually is T1 hyperintense. Then we again employ our frequency selected fat suppressed sequence and bring out the areas of hemorrhage that we see in this particular case, in this case of endometriosis. And we see that these are hemorrhagic ascites with small endometrial implants along the side of the uterus. And this does not represent fat, this indeed is hemorrhage. We can also do dynamic pelvic floor imaging. Very easy, non-invasive tool to evaluate the integrity of the pelvic floor. This is just an example of a patient whose status post-hysterectomy with a large cystocele, as well as some degree of rectal prolapse, milder. There are recent advances in MR and continued advances in MR. There are stronger and faster gradients which enable us to image with higher temporal rate as well as better spatial resolution. We have high field imaging magnets up to 3T, which are approved for clinical use and offer some other advantages which I'll mention. our coil technology has improved. We can now perform whole body imaging, which has tremendous implications for evaluation and monitoring of patients with malignancy. I just want to talk a moment about parallel imaging and how that has changed our imaging technique. Parallel imaging is a newer technique which allows us to use not just the coil, the body coil for reconstructing data, but also the phased array, the coil on top of the patient to reconstruct data, to decrease your number of phase encoding steps that you need to take, and to reproduce that information or to sample that information from the coils themselves to get a full image. This enables us to reduce our number of phase encoding steps, which means that we can shorten our scan time or use that extra time to improve our spatial resolution. And parallel imaging becomes very useful and even more easily performed at higher fields because we have higher signal to noise. Here's an example of a patient. This is at 1.5 Tesla, but this is with parallel imaging. We can see that here we have a large fibroid uterus, a large fibroid within the uterus. You're only partially imaging the uterus here, as well as a left adnexal mass. Well, typically, our T2, we do multiplanar T2-weighted images. We do axial, sagittal, and coronal views. Each can take up to 6 minutes, depending on the size of the patient's uterus or whatever pelvic pathology that you see. So this could be 18 minutes of your examination. With parallel imaging, you can maintain your spatial resolution and cut the examination time in half. And really, I feel that you can see here that there's really no significant compromise in image quality, and in fact, you have less artifact from respiratory or patient motion. So you can cut your exam time from 18 minutes in T2-weighted images to about 9 minutes or less, depending on patient's anatomy. Whole body imaging, although not discuss it at great length, I just want to mention that it's now feasible and to consider using MR as your follow-up tool for patients with malignancy to see response to therapy, as well as to look for bone metastases. So it's just an idea to keep in mind. And again, with parallel imaging, it makes it possible to do this in a very reasonable amount of time. So these are some images that we've recently acquired on our 3T magnet. And one of the advantages and one of the things that we can push on the 3T is because of that high signal to noise I mentioned, you can really push the limits of resolution that we've previously incurred. So we can do a small field of view, 180 field of view, get a voxel size of a sub-millimeter voxel size, and image in just 2 to 3 minutes. And here you just see excellent image quality. You can still see the zonal anatomy, even in a small, normal uterus, and really get great insight into the endometrium, and it really is very hopeful for us to see even more in the female pelvis. So it's just an active area of research. This is one of the first cases where we had a patient at the 3T with a large uterine mass occupying the uterine cavity and extending, infiltrating into the myometrium. And this turns out to be an endometrial carcinoma, happened to be a mixed Mullerian duct tumor, a sarcomatous lesion. But we can see also one of the other benefits of high field and the fact that there's fat and water separation is higher at the higher field, and that chemical shift can be taken advantage of by getting better fat suppression, more selective fat suppression. You can see the homogeneous fat suppression in this particular T1 fat suppressed sequence. And you can, with gadolinium, see the extension of this tumor into the myometrium. Now, there are limitations of MR. It is costly. It's limited in availability in some places, and not all patients are candidates for MR. Patients are claustrophobic, patients have pacemakers. There's certain things that may not make the patient amenable to MR. And again, it's useful for fetal imaging and as an addition to ultrasound as a problem solver, which I won't talk about as much. But again, in the early trimester, the first trimester, we tend to avoid MR if we can, because we really don't know the long-term effects, although we suspect it's probably not a problem. So let's move on to talk about the role of MR in the female pelvis. Really, the role of MR is as a problem-solving tool when ultrasound and CT are insufficient in some way, and you need more definitive characterization of masses or more clear delineation of the anatomy. It's also, as I mentioned, useful in pregnant patients and can be useful, as Dr. Kramer pointed out, in staging of endometrial and cervical carcinoma. So our standard protocol that we use, we do a multiplanar scout. We get our T2 turbo spin echo images. We try for high quality, high spatial resolution imaging. We also do T1 in and out of phase imaging, also to look for smaller amounts of fat within lesions, and to look to be able to compare those T1 without fat suppression to our post or pre and post contrast fat-suppressed T1 weighted images. We also try to include coronal haste imaging, particularly in patients who are presenting with infertility and potential Mullerian duct anomalies, so we can make sure that we evaluate the kidneys as well, make sure that there's no GU malformation associated with a Mullerian duct malformation. With parallel imaging, we can really cut our examination time to about 20 minutes. So let's start with the cases, and things get interesting. And here's a usual diagnostic dilemma on hysterosalpingography. Here we have two uterine cavities opacified with contrast. We see rather acute angulation in both cases, and it's really hard to distinguish just with hysterosalpingography which one is the septate and which one is the bicornuate uterus. It's a common problem. And it's very important to distinguish between the two because they have different risks of reproductive outcome as well as differences in management. So it's important to make that distinction. On axial ultrasound, the appearance of these two entities can look quite similar. This is actually a saline infusion ultrasound. And what's important in these cases is to get a good coronal view. And if you're not able to achieve that either with conventional ultrasound or 3D ultrasound, then MR may be helpful to you. And in this case, we can see, and the most important thing to note again is that fundal contour. We can see the flat fundal contour of the septate uterus and the deep septum here versus the divergent horns here and the deep fundal cleft in the bicornuate uterus. It's also helpful to look when there's other pathology present and to look at the extent of the septum as well as the single characteristic of the septum, whether it looks more fibrous or more muscular, which may help management decisions. So once again, septate is actually the most common anomaly and unfortunately has the highest associated risk of reproductive failure. The difference in surgical procedures are that the septate uterus can be managed hysteroscopically with removal of the septum, depending how extensive that septum is, whereas the bicornuate may not need treatment at all, and if so, it would need a more extensive procedure. So the role of MR in uterine anomalies, as I touched on already, is when the ultrasound is indeterminate, when there are cervical or vaginal malformations that make you unable to really do an endovaginal examination or unable to cannulate the cervix due to cervical stenosis or absence of the cervix for hysterosalpingography, and also for the evaluation of unicornuate uterus or more complex anomalies when it may be difficult to decipher on ultrasound. It's also extremely useful when you have other pathology, as I mentioned, which can distort the uterine cavity and particularly make it difficult to delineate the anatomy on hysterosalpingography. Here's another case where we have a hysterosalpingogram with opacification of one uterine horn, and it has the appearance of a unicornuate uterus. On MR, we see the typical banana shape of a single uterine horn. We see the normal zonal anatomy and normal adnexal as expected. However, take the same, this is the unicornuate most common type, take the same hysterosalpingogram and then go to MR, and in this particular case it's slightly different. We do see a unicornuate uterus, but there is an exophytic mass projecting off the uterus here, extending towards the right into the broad ligament region. Here's the normal right adnexa, right ovary rather. And on the axial views of the uterus, you can actually see that this looks like a small uterine horn, and it's actually a rudimentary horn that is not communicating. And this becomes important in terms of the surgical management, because when you have a non-communicating rudimentary horn, it may require surgical intervention because it can get obstructed and cause problems. Here's another interesting case. It actually came through the pediatric service, a patient who was known to have absence of the vagina and wasn't really able to do anything more than a transabdominal examination and was found to have bilateral adnexal masses on ultrasound. So she presented to MR, and we can confirm the absence of the vagina here on this transaxial view, and also on the sagittal view. We see that there is no cervix and no midline uterine tissue, and can confirm all the suspected findings on ultrasound. However, we can go a little bit further and look at the adnexa and note that there are two small rudimentary horns that are in the broad ligament region, and these are actually just unfused rudimentary horns, and a very unusual variant, but very easily depicted at MR and very quickly seen. Here's a more challenging case that was sent to me by one of my former colleagues, Dr. Brock Friedman, who's now at LIJ. And he sent the case because it presented a difficult clinical situation. They were trying to evaluate this patient who had no Mullerian duct anomaly. They knew that there was obstruction. But here we see a deep division and appearance of two uterine cavities, and there's this septum between the two. And the important thing, again, to note and to fall back on is to get a good view of the uterine contour. And we have one here where we see that there's a slight convexity of the uterine contour, but not significant enough. This is not a bicornate, but a septate uterus with an unusual variation where we have a complete septate uterus. And in addition to that, we can go further and see that there are actually two cervices here and a septum within the vagina. The obstruction helps us better visualize the vaginal cavity, which may not be as well seen on MR, but we can see the hemorrhage and debris within the septated vertical septum within the vagina. So this is fairly easily diagnosed with a little patience on MR and really looking at that fundal contour, which really helps you delineate this from the bicornate uterus and make the accurate diagnosis of a septate uterus with a complete septum, duplication of the vagina, and a vertical septum in the cervix. And this is an important distinction to make, and in management, although controversial in these patients, it takes a lot more surgical planning and some decisions that need to be made before going in with this patient. Here's one final case of case with infertility where we have an HSG again, and we see that the uterus has a slight indentation of the endometrial cavity at the fundus, but more importantly, there's a large amount of mass effect on the uterus, which is pushing it to the left. There's a smooth contour between that mass effect and the uterus, such that it may suggest an intramural uterine mass or some other pelvic mass impressing upon the uterus. With MR, it's very easy to do two things: to first evaluate the uterine anomaly, if there is one, as well as to evaluate that pathology or suspected pathology. And in this case, again, we can see a smooth uterine contour, a slight indentation of the superior aspect of the fundus in the endometrial cavity, probably an arcuate type uterus, as well as a large intramural mass, a heterogeneous mass, but predominantly hypointense and suggestive and consistent with a fibroid. So you easily can see fibroids as well as delineate the anatomy of the uterus all in one sitting. Just to briefly talk about the role of MR in fibroid evaluation, the role of MR is really preoperative and postoperative assessment. We can look at and determine the size of and location of the fibroids, as well as distinguish between a fibroid or an adnexal mass. Often that can be a diagnostic dilemma. We can also make some suggestions in terms of preoperative planning and determine whether there are pedunculated fibroids, which may not be amenable to uterine artery embolization, for example, or whether there's a large pedunculated submucosal fibroid, for example, which again may be preferably removed hysteroscopically. And we can also assess these patients in the postoperative state. You look for necrosis or removal of the fibroids. Here's a case where a patient presented to ultrasound, and we see that there is a large fibroid within the uterus. Hard to see whether it's submucosal or intramural, but we suspect it's probably submucosal. We probably see a little bit of the endometrial stripe here anteriorly being pushed anteriorly, but it's somewhat hard to distinguish how deep within the wall the fibroid goes. So they did a saline-infused hysteroscopic ultrasound evaluation with saline infusion. And we see a large fibroid here, but we see it's definitely submucosal. We can confirm that finding, but the extent of the posterior extent of the tumor, or the fibroid, and its extent into the wall is sort of indeterminate here. And the posterior wall can be very difficult to see on ultrasound. And this is very crucial because, again, it will determine management. Can this be amenable to a hysteroscopic resection, or we're going to have to go in do a resection of the fibroid and cut into the uterus? On MR, it's really more clearly distinguished. We can again see that large submucosal component, but we can see the extent of that fibroid into the myometrium. It goes quite deep into the myometrium, and this patient may be better off getting a myomectomy rather than a hysteroscopic approach, as well as other fibroids become apparent that may be non-visualized on ultrasound. Here's another case where we have a left adnexal mass. It's a homogeneous mass, but it has vascularity, and it's unclear whether this is actually rising from the ovary or the broad ligament, or possibly a pedunculated fibroid from the uterus. So the patient came to MR, and we can see that there's a large intramural fibroid here posteriorly, as well as a mass here in the left adnexal region. Now, the mass was completely separate from the uterus. We were able to prove that on MR. We can see that cystic lesion that corresponds to the abnormality we saw on ultrasound. And we can actually make, with more imaging as well, see that there was actually no communication between this mass and the uterus. In addition, we note that the signal intensity of the mass is not similar to fibroids, which should really be more hypointense. It's more intermediate in intensity. So we can tell now that it's not uterine in origin. It appears to be at least ovarian or adnexal in origin, and it does not demonstrate similar characteristics that would suggest a fibroid either, and like a broad ligament fibroid, for example. And then we become more concerned that this is something that has to be removed, and it's probably a solid ovarian tumor. And in fact, this case turned out to be, it's a normal ovary on their side. This turned out to be an unusual case of a Sertoli-Leidig tumor. Here's another case seen on ultrasound. We see that on the sagittal view, there's thickening of the endometrium, probably a small polyp within the uterine cavity. The left adnexa, there appear to be a left adnexal mass seen here adjacent to the lower uterine segment. There seemed to be flow within the adnexa, but it seemed like it was basically a solid mass. There were no cystic follicles. A normal left ovary was not visualized. The patient came to CT, and that's actually why that went next. And the mass is seen here and appears to be about 50 Hounsfield units. The patient had surgery, and there was a question whether this represents a fibroid or a collection, because what happened was that as we go higher up, we begin to see a small focus here that looks like a normal ovary. And we had the sense that this is actually not ovarian in origin at all, but in fact a mass arising from the uterus or a collection adjacent to the uterus. We chose to go to MR in this case to try and distinguish between a collection or some kind of fibroid or degenerating fibroid. And what was interesting in this case, we see the polyp here in the endometrial cavity that we noted on the ultrasound. And we also see, here's bowel here. It can be confusing, bowel and hypointense masses, but you can see bowel here and the mass projecting off and attached to the lower uterine segment and upper third of the upper portion of the cervix. We can see on the coronal image the mass here, and we see actually a small stalk, a thin stalk, and a mushroom appearance of this mass. And on contrast-enhanced imaging, you can see it's a vascular fibroid, and we can clearly see higher up a normal ovary on the left side. So here we are very confident that this represents a pedunculated fibroid and can be managed accordingly. Here's another mass, also suspected to be a cystic adnexal mass on ultrasound, but on MR, again, we can see a normal ovary with small follicles on the left, separate from this bilobed mass, which appears to be arising in the intramural location. It is heterogeneous. It has cystic degeneration, but this is also compatible with a fibroid that has cystic degeneration. Fibroids can have variable appearance. They can have areas of hemorrhage, areas of necrosis, and you have to be somewhat careful. And it's very hard to distinguish between these and malignancy. So if there's any question, you have to go by physical examination, assessment, interval growth. There's really nothing on MR that can tell you, tell the difference between a sarcoma or just a normal fibroid. But generally, if you become familiar with the appearance of fibroids, you can be fairly confident this just represents a degenerating fibroid. Here's another case that presented to ultrasound. Patient had bleeding, and there appeared to be thickening of the endometrial cavity, as well as this heterogeneous, fairly intermediate echogenicity mass here within the endometrium. Its margins with the myometrium were somewhat indistinct, and it was very difficult to see whether it represents a neoplastic process or perhaps adenomyosis. So the patient presented to MR, and we can go back to that junctional anatomy that I pointed out before. That zonal anatomy becomes very important, particularly when trying to diagnose adenomyosis. We can see the normal junctional zone here, and contiguous with the normal junctional zone is this thickening, this thickening all the way, almost all the way around, circumferentially in the uterus, and as well as these small cystic spaces, making very confident the diagnosis of adenomyosis. Now, adenomyosis can be focal, as in this case, or it can be diffuse, as in this case, where we really don't distinguish any normal junctional zone. The entire uterus was replaced by adenomyosis and these cystic changes. Oftentimes, you can see adenomyosis and fibroids in the same setting. Here we have a large fibroid, and here is, again, that focal adenomyosis. The distinguish between the two that can be some of the distinguishing characteristics between the two that can be helpful to use is that the fibroid tends to be lower signal intensity, well circumscribed. This is an intramural example, but as we saw in the submucosal example, can really deform the endometrial cavity versus the adenomyosis, which tends to not deform the endometrial cavity. And also, one of the problems with ultrasound in these cases is we have fibroids and adenomyosis. It's very hard to distinguish between the two. One thing you don't want to confuse this with is this case here, where we have focal thickening in the junctional zone, slight distortion of the endometrial cavity, as well as these dark bands within the uterus. And this is more typical of a uterine contraction. We can confirm that suspicion by looking at delayed images. Here's the post-contrast images in this patient done a few minutes later, where we can see this is totally resolved, and this is just a uterine contraction. If there's any question of that, you can bring the patient back or wait a little bit longer and examine the patient again. One of the things that we're trying to do more of is, for evaluation of vaginal and cervical pathology, is to use endovaginal contrast. What we use is basically ultrasound gel, self-administered by the patient on the table. And it allows us to give contrast into the vagina, and in cases of Mullerian duct anomalies, for example, you potentially could see septa that you would not otherwise appreciate, whereas in this case, you can evaluate this submucosal vaginal mass. It's very homogeneous and hypointense in signal intensity and characteristic of a vaginal wall leiomyoma. You have to be a bit careful in these cases because you can introduce small air bubbles that should not be confused with filling defects within the vagina. And this is just an example. I was just going to touch a little bit on malignancy. This is a case of cervical carcinoma where the vaginal contrast was very helpful because we can very well distinguish and give a good, accurate size of this posterior cervical carcinoma here, and we can confirm that there's no extension into the vagina or into the endometrial cavity. So here we can give an accurate size, which helps with the staging of cervical carcinoma. I'm just going to move now on to the perineum. And so oftentimes we're asked to look at the urethra or look at periurethral masses. They can be a bit confusing, so I just want to go over a few types. Here we have a teardrop-shaped hyperintense on the T2 weighted images, fluid fluid signal intensity focus, and it's located actually at the urethral meatus. We can see that it's actually not within the vagina and anteriorly located in the sagittal views. It's very distinctly related to the urethra. This is more suggestive of a submucosal cyst or a Skene's gland cyst, often a sequela of inflammation and abscess formation. When infected, they can present as fluctuant masses and may be surgically excised. So it's important. The distinction that you really need to make is where these cysts are arising from. And that's why it's very important to get good thin section images, angulated particularly to the urethra and vagina. And this is in contradistinction to the Bartholin's gland cyst, which is also located low down in the perineum, but it is associated with the labia majora and not with the urethra. And we can see here that we're slightly parasagittal here. We're sort of beyond the margins of the urethra, and this is clearly within the labia and characteristic of Bartholin's gland cyst. The other differential included in this is a urethral diverticulum. They tend to be higher up. It can be low-lying. You try and see if there's any communication between the diverticulum and the urethra, but that's hard to see sometimes. They tend to have this horseshoe-shaped appearance here. And the dreaded complication, however, in these cases is stone formation and adenocarcinoma, so it's important to look for those things as well. Here's a more unusual case. The patient has a suprapubic catheter. The bladder is somewhat collapsed. And here's the urethra here, which is markedly inflamed. There's high signal. First of all, the signal intensity of the urethra is abnormal. It's edematous. It's more hypointense than you expect. And circumferentially surrounding the urethra is this hyperintensity that's more complex than simple fluid. And one important question to ask when evaluating patients with urethral pathology is whether they had any procedures such as collagen injection, which is sometimes used for incontinence. And in this particular case, the patient had a collagen injection, and this was a complication where there was a marked inflammatory response, and this should not be confused with a diverticulum of the urethra. Next case is, again, we're moving a little bit into adnexal masses, and Here we have a large central cystic mass in the pelvis with multiple septations. The ovary seems a bit separate from the mass and displaced laterally by the mass. On MR, we can see that, again, it's centrally located. It's pushing the ovary peripherally, and it doesn't really seem to be arising from the ovary, but pushing the ovary off to the side. And this is more typical of a peritoneal inclusion cyst. And these are typically patients who've had surgery, and they can have a variable appearance. The ovary may get entrapped. It's patients who are still hormonally active, and it's usually due to fluid accumulation in these cases. And normal physiologic activity of the ovary may lead to the development of these large cystic masses. They tend to cross midline, and again, they sort of they don't exhibit a lot of mass effect in that they're just sort of conform to the confines of the pelvis and push organs away. Sometimes MR is very helpful for more complex adnexal masses, as in this case, where we can clearly see that on the T1 fat suppressed images, we have high signal within this adnexal mass with debris. We see the T2 shading characteristics of this entity. And with subtracted images, we can confirm that there was no significant internal enhancement, maybe some thickened septation. This is typical of an endometrioma. We also look for other signs of endometriosis in these patients. You want to look for multiplicity of lesions, peritoneal adhesions, hemorrhagic ascites, as well as hemorrhagic implants, as I showed in the previous case. Here's an example of hematosalpinx we can see oftentimes in these patients with the layering hemorrhagic fluid, or as we saw in the previous case, these small implants and hemorrhagic ascites. Here's an interesting case. The patient had cyclic suprapubic pain and was found to have a mass on the superior portion of the bladder. The bladder is not very distended, which made it very difficult in this case, but we were questioning whether this was a mass exophytically coming off the uterus or actually a bladder mass. On subsequent images, the bladder filled up. It became more apparent that this was already in the wall of the bladder and was associated with sort of some unusual appearance of the myometrium, the appearance of adenomyosis. On post-contrast images, you can see this is enhancing, which can happen with endometriotic implants, and this is suspected to be endometriosis involving the bladder. So one more case. This is a complicated case that presented to the emergency room at Bellevue, patient with a lower abdominal pain. In the emergent setting, they proceeded to CT to look for bowel or pelvic pathology. On CT, we can get the sense that there are actually there's an unusual-looking uterine horn here, what looks like possibly a second uterine horn here with fluid within that cavity, as well as a large left adnexal mass, as well as ascites. In this patient, it was suspected this might represent a tubo-ovarian abscess, so the patient came to ultrasound. And on ultrasound, you can again see that there looks like there's two divergent uterine horns, has the appearance of probably either a bicornuate or unicornuate uterus with an obstructed horn, as well as this complex adnexal mass, which is suspected to partly at least represent a hydrosalpinx. The patient came to MR for further characterization of these masses and further delineation of the uterine anomaly. And we can see here that, in fact, what we have is, again, that unicornuate uterus with a small exophytic obstructed and non-communicating horn. And we can see that there's a hemorrhage fluid level within the endometrial cavity of the obstructed horn. And we can also appreciate that in the adnexa, yes, there is a hematosalpinx as well as the hemorrhage within the obstructed horn. The patient also had absence of the left kidney and an unusual variant as well in the pelvis. I noted a lack of the absence of the left iliac and external iliac vein, and an unusual vein coursing actually in the presacral location. So all these things were extremely helpful in terms of planning of how to deal with this mass.